Aloysius College, Professor Betsy Palsy, Director of Research, Susan Joshi, Head of the Department, Dr. Christinez, Ratna Kiruba, today's presenter, and Dr. Gayathri Sharma, our moderator, and I welcome all the participants on behalf of Chrysalis team to today's session. With all the blessings from the Almighty, we are here to enrich you with another informative session. Chrysalis endeavored to celebrate academic legacy and foster intellectual exchange. Starting from humble in-house lecture sessions in November 2021 to pay homage to former teachers of our department, Reverend Father Anthony Kuttikat CMI, Dr. Danya Menon, and Professor Paul Davis, the lecture series has emerged into a dynamic platform for researchers spanning from distinguished professors to emerging scholars who reaffirm the relevance of literary studies and the humanities in an increasingly automated world. Today, we proudly invite our speaker, Dr. Christinez Kiruba, resident physician at Satribai Christian Hospital, Guwahati, Assam, and freelance journalist and lead editor at Nirvana, a digital health journalism platform. She's interested in viewing public health issues through the gender lens. I welcome you, ma'am. And our moderator for today's session, Dr. Gayathri Sharma, is a public health worker and emergency medicine physician with experience in community health, clinical practice, and health system research. She has worked with various organizations, and is currently involved in multiple initiatives, including coordinating the travel fellowship at the Rural Healthcare Collective, serving as creative editor of Nirvana, and contributing as a researcher at UNU IIGH study on the effects of corporatization and financialization on clinical practice in healthcare institutions in India. So I welcome you also, ma'am. Now it's all yours.
Thank you so much. My first request would be to call me Gayathri, so that we can speak freely and we don't have to worry about hierarchy. So don't worry about doctor or ma'am, please. Good evening, everyone. I'd like to thank the organizers for having me, and I look forward to learning from everyone today. Um, I'm happy that there are people from various different backgrounds that attend, and that we can have this sort of cross-sectional learning, because each perspective matters. Um, so today's session, I think, focuses on a theme that sits at the intersection of healthcare, ethics, and gender justice. So we're talking about how much agency exists for women in healthcare in India. So if I could just quickly begin with a set of stories, I won't take too much time. But recently I met somebody from an underprivileged community in Mumbai, who was denied access to registering for antenatal care, uh, because in three institutions, because her husband didn't have an Aadhaar card. So she had an Aadhaar card, but her husband didn't have one. And eventually, she had to go to the only hospital that would register her. The care was not so great, and she did end up landing in with a very bad infection and a stillborn baby. And this is happening in an urban area, in the heart of Mumbai, where there are enough hospitals and healthcare institutions available. So I mean, I would like to ask all of us to ask this question: whose agency did she really have agency over her health? And even if it was not her agency, did the family have any agency? But definitely the female did not have any agency in what would happen to her, what would happen to her baby. And also, the second story I'd like to share is that I was speaking to somebody who looks after children's kidneys, so pediatric nephrologist, and they often come in contact with children of all ages who have kidney disease, and sometimes very life-changing decisions have to be taken for these children. And very often, what happens is that after explaining everything to the mother, she is not able to take that decision, and the decision for what will happen to the child is often taken by the family. And sometimes uh, the family finds it easier to say, we don't have the money, let the child die. Whereas if the agency was left to the mother, maybe the decision would be different. So, when we speak about agency in healthcare, we are referring to a person's ability to make informed decisions about their own body, their treatment, their reproductive health. But in theory, this is supposed to be a foundational principle of medical ethics. But in practice, the exercise of this autonomy is often shaped by a complex web of family expectations, social norms, institutional policies, structure inequalities. And it is important to note that autonomy in healthcare, whether it is for men or women, it's rarely purely individual. It is mostly relational, shaped by family structures and social expectations and economic realities. At the same time, I find it absurd that in a healthcare system that is running mostly on the shoulders of women, that is, nurses or ASHA workers who bridge that critical last mile of healthcare delivery. In such a healthcare system, women have the least agency over their healthcare decisions. And so, despite wanting to do the right thing, for many healthcare professionals working on the ground, um, supporting the woman's agency can still involve navigating very difficult tensions, whether it's between clinical judgment and patient preference, between institutional protocol and individual rights, and sometimes between the woman's own choice and the pressures surrounding her. So today's talk invites us to reflect on these challenges within the Indian context, while also thinking about what any meaningful systemic change might look like. And so it's my pleasure to introduce my friend and our speaker, Dr. Christinez Ratna Kiruba, who finished her post graduation in internal medicine from Christian Medical College in Vellore. Is currently a resident physician at Satribari Christian Hospital in Guwahati in Assam. Has done studied journalism for health impact from the University of Toronto, and is the lead editor at Nivarana, which is a digital health journalism platform. Over to you.
Am I audible? Yeah. All right. So I will be sharing my screen and I will be presenting my talk in the form of a PowerPoint presentation. If you can just wait for a second, please. Um, okay. Are you able to see this?
Yes.
Yeah. Okay. Right. Just a minute. Okay. So, my topic for today, what I'm going to talk about is female healthcare agency, by which what I mean is how much are women able to make decisions about their own healthcare in India. So, what challenges that we face on the ground, and what learnings that I have um, had over the years of facing these challenges. Now, when Betsy ma'am approached me to take this lecture, what I was very clear about, and after having attended other lectures on Chrysalis, was the fact that, like, I am not someone who is well versed in English literature, especially the last lecture on how children's literature would help construct identities of nationalism versus global identity for children. I was a little bit panicked, so I reached back to ma'am again and said that I have no idea what is happening on the literature front. What I am is a doctor. I am an avid reader of novels, very mainstream novels, like um, not niche or not things that you could take interesting takeaways from. I don't understand the technicalities of um, English literature per se. So what I will be talking here is will be completely from my experience and the experience of my colleagues on the ground, what I have spoken to them, and from some of the very, very mainstream novels that I've read and liked. So with this introduction, let me start off with a novel which really inspired me to think about what autonomy for women looks like in South Asian societies, which is The Vegetarian. Now, the quote that really spoke to me was this one. It says, "It's your body. You can treat it however you please. The only area where you're free to do just as you like, and even that doesn't turn out how you want it." So, the context for what this for how this happens is that the eponymous vegetarian, the titular character of this novel, um, at one random point in time, she decides that she cannot take the violence that is so pervasive in society. So she decides that in her life, she will be a vegetarian. However, this is set in South Korea where meat eating is very widespread and it's the norm. Now, something as innocuous as a choice to you know uh, decide what you would eat then becomes very, very difficult for her, as it goes through her entire family resisting this choice. You would see her husband getting mad at her for deciding this because he's worried she would not cook anything with meat for him to eat. How his family members feel very um, what do you call it, insulted in public to be seen with somebody who is so particular about her food choices. Eventually, as we go through the book, we realize that it is the fact that a woman has made a particular choice about her body that disturbs everyone much more than the choice or its logical validity in itself. Like, if we look at it, it's a very simple and an innocuous choice, but people are so disturbed and worried, and they start becoming increasingly violent towards this person because of the fact that the that she has made a choice in itself. So this is a very beautiful book that shows how women's autonomy is stifled uh, in various parts of the society, and it really spoke to me. And if anybody has, like, if you are interested, you really, really should read it. So what constraints to female autonomy do I as a doctor see on the ground? um these are just a collection of quotes. I've seen women in labor scream for pain medicine, but husbands and mothers in law refuse epidural, which is a form of pain relief. It's traumatic. This is one of my colleagues who is an anesthetist. Anytime I explain breastfeeding options or reproductive choices to women, they always say that it's not their decision to make. It's always a family decision. It's obvious that these women do not have an inch of autonomy over their own bodies, says Shaba. She is a rural community health center doctor from Andhra. Doctors sometimes do not even explain anything regarding the condition or treatment options. They adopt this approach because after spending a considerable amount of time explaining to the woman, she almost always asks, "Could you explain this to my father or husband or brother?" So they stop explaining to the woman because they think they will have to explain twice. This is Dr. Aslam, he's my partner. So though also in India, a woman does not need a husband's consent to have abortion, this right appears to be only on paper. Many health providers actually feel very uncomfortable offering reproductive care like contraception or abortion for unmarried women, or even women who are married but are not accompanied by their partners or family. So they request that spousal consent be given. One would think that this happens only to women with no agency, but that's actually not true. What I have noticed in all these years of working on this is that women who are successful in other spheres of life, even women community leaders, do not have much of a say when it comes to their own sexual and reproductive rights. Says Subhashri, she's a rural gynecologist who has worked on this for a long time. Now, beyond this, what can happen is that sometimes relatives even request doctors to hide from the woman the diagnosis or details. So, this is known as collusion, and this happens very, very commonly in India, especially in terminal illness settings. Now, this can happen when it's a woman or a man, but it's statistically way more common that family members would request doctors to hide diagnosis from women. They think this is because women are very emotional and they will not be able to handle the diagnosis or whatever. So, and in my own experience, like a patient who had a type of advanced cancer and she was very young, she was just married, did not have babies, came there with back pain, and then, we did MRI and that showed some cancer that had spread to her spine. Now, she wanted to know what was happening to her, and so I was one of the junior doctors around. So I told her, I revealed what was, and she thanked me because nobody, including the senior doctors, had told her anything. Like the husband had requested the senior doctors not to tell her, and so see, like the patient is admitted in cancer ward. Everybody around her is a cancer patient. Now the request from the relatives is that you don't tell her what is happening. So even if we don't tell them, right, they do feel something is going wrong, and which is what many studies on collusion actually show, that patients do realize something wrong is going on. They see that the relatives are crying, they're going out of the room and talking to the doctor. They're not like, so they do understand. And also when they're not getting better but the relatives are saying, okay, you're getting no, this is just a simple thing, you're getting the right treatment, they're just like left very confused. Who do they trust? Like the people who are they're supposed to trust are lying to them, right? This is yeah, so this is also like a very insidious form of taking away autonomy from women that very commonly happens in collectivistic cultures, especially like in India. Now, let's look at the numbers. Like 80% of Indian women need familial permission even to go to visit health centers. About 5% of Indian women have sole control over who they marry. So we understand that like Indian women have very less autonomy in all aspects of their life, not just healthcare. Um, the Another study eventually later showed that of these 5%, right, 9% of women were college educated women. uh, it's amusing that somebody with college education or such levels of higher education, among them also only 9% can choose their husband. That number falls to 2.2% if it's an uneducated woman, especially if they're from rural areas, by the way. Contraceptive decision making in India is also at an all time low. Women are not allowed to make decisions about whether or not they need contraception, as well as what kind of contraception they're going to be using. And this is known as surrogate decision making, which means that an adult who is competent to consent and choose should be consenting and choosing for themselves. What happens when in medicine we call surrogate decision making is when somebody is mentally incapable of choosing, like for example people with mental health conditions like schizophrenia, where they're not in touch with reality and they're unable to make choices for themselves. Then they sometimes choose a surrogate decision maker. Or people who are about to go into a coma, they're very old, so they may say my son will make this decision about my own healthcare for me. But then if you see, like this kind of surrogate decision making is happening for Indian women who are not falling in any of these categories. They are for all intents and purposes adults who are capable of understanding information, processing information, and thereby asking for what they want. But it's so common that other people are making decisions for them. Now, Why is that the case? So again, I would like to talk about another one of my favorite books, which is The God of Small Things by Arundhati Roy. That it really all began in the days when the love laws were made, the laws that lay down who should be loved and how much. By which we mean that caste endogamy is the reason why no amount of autonomy is awarded to women in India. If we see, people want women to marry within their own caste, and women's bodies are used as a vehicle to maintain caste and religion and whatever social structures there are. Now, if a woman has any amount of autonomy over any aspect of her life, then it is likely that she may choose somebody who falls outside of the caste. So for that reason, and to ensure that, lineage, property, resource control, all is maintained within certain caste structures, is why women do not get any autonomy at all, much less reproductive autonomy. Now that is, again, even if you don't get reproductive autonomy, even women who go to school for the first time, or women who get educated or get employed, if you see, as soon as they start showing any kind of interest in somebody of the other gender, the first thing the parents do is just kind of pull them back and stop all that and like marry them off to somebody else. So it's very clear that caste endogamy and lineage and inheritance and resource guarding is what is leading to the lack of autonomy that Indian women face. And then look at this. This is an excerpt from Heartland, where a woman is waiting to meet one of the religious leaders to discuss an issue that she's facing. Another woman who's waiting there with her says, they say those who get an operation done to stop getting pregnant will not reach Jannat. Is that true, Ashraf? She says, I don't know what is true. I have to ask somebody else who is educated because she is reading a lot of fact books. Then this person tells her, if that is the case, will you ask her and let me know next time that you are there? So we see that religion also, again, a huge social structure that maintains um, a role over what decisions women can make. I'm not here to say that Islam, which is what is being revealed in Heartlamp, is the only religion that does that. We see that all kinds of religions where they are conservative, for example, Christian nationalism in the Americas, are always take a stance which is anti-choice and anti-autonomy to women. So um, this book is also brilliant. It's a non-fiction book that I really, really like, called Seeing Like a Feminist by Nivedita Menon. She says that the idea of controlling women's sexuality is central to patriarchal power. So, in that way, the family, the community, and the state are all invested in ensuring that a woman's sexual behavior is monitored and regulated, as it is tied to notions of honor, purity, and lineage. So, this is kind of the nutshell of what I'm trying to say. Even if the idea of monitoring women's sexual behavior ends up becoming what people used to monitor literally every part of women's lives, because they do not want them to accidentally step out and do something that would threaten social structures and the construct of family as we have now. So let's talk about the state, because now if you see, in Tamil Nadu, the state where I originally am from around 2012, there has been a shadow ban on the emergency contraceptive pill. If you try to go buy it from any pharmacy, well, I would say emergency contraceptive pills are supposed to be over the counter, they don't need prescriptions, but no pharmacy in Tamil Nadu stocks it. And it's So that's called a shadow ban, which has been happening. If you see in Chhattisgarh, there were certain vulnerable tribal groups for whose demographic preservation, the government was banning them from getting any access to reproductive choices because they thought they wanted these people to, the numbers of the people to be maintained. Um, Now, recently, last year, what had happened was Tamil Nadu tried to push it to make it national that emergency contraception should not be available over the counter. So, a lot of activists and a lot of journalists came together. We sort of worked on it, put it out in the newspapers on how it's really safe, how WHO recommends that ECPs be available over the counter, and sort of they things happened which made it make sure that it still remains over the counter. Now, the black um, thing that I've put up, that is one of the most interesting and my most favorite thing that had come out on Scroll this year. Because, like, when you talk about reproductive health, right, like, ideally, how many kids should a woman have? As many or as less as she wants. But that isn't how India or any other nation functions. Like, we look at population manipulation as solution for a lot of our issues. For example, we were pushing family planning for a certain amount of time, and now that delimitation has come up, now south states are again asking people to have more kids suddenly to ensure that the Lok Sabha seats remain um, distributed appropriately. Somehow, India's demographic anxieties play out on women's bodies. Nobody really cares what the woman wants, what's good for her, what's good for her family. So these are somehow, when we talk about female autonomy and her decision making about her own body, we tend to really think about it as it's a relationship between the individual woman and her physician. However, it's not that. um, like, her body is used as a conduit for many social structures, including the state, to kind of like manipulate how things happen. So very less actually happens between the physician and the woman in that sense. So let's add more nuance to this. Like, we now understand that it's a moral imperative for a woman to make decisions about her own body, right? Like, um, whether or not anybody likes it, it's morally imperative. All of us want to do what we want, and then when it comes to something like our own body, like, we don't even eat things we don't like. So technically, we want women to make decisions about their own body, especially considering medical procedures. But today, if at all today, as a medical doctor, I just refuse to take any familial input, any societal input, and tell a woman, isolate a woman and tell her, you have to make your own choices regarding your health. What do you think would happen? More often than not, the patient would refuse to make a choice. The reason is, and this is something that Aditi Iyer, one of the gynecologists I had met at a conference, told me was, imagine this woman. She has in her entire life not made a single choice. She had not had a choice in doing anything. Whom to marry, when to have a child, nothing. Like, what she should study, where she should go, what she should buy from the store. If the first time she's getting to choose for herself is in such a high stakes situation, like when she is sick or when she's having a baby, and you know, something huge can happen if she made the wrong choice, she would feel intimidated, not empowered to make that choice. So we have to, yeah, so this is a very important nuance that we have to take into consideration. When I worked in a PHC, I had more freedom to encourage women to make choices because those choices were paid for by the government. This is something that my partner used to say because once in private settings, what happens is the family controls the cash flow, and if they control the purse strings, they're going to control the decisions. So, in government setups, arguably, it might be easier to encourage women to make their own choices. Um, A doctor once performed an abortion on a patient who wanted it without her husband's consent. Next day, a group of family members led by the husband came to the hospital and threatened to kill the doctor. This is said by a gynecologist on condition of anonymity. So, as you say, like even if today I want to offer this choice to a woman, I would be doing it at the risk of my own well being, considering the societal backlash that is definitely possible. A patient who had come for an antenatal checkup timidly asked me where in her body the baby would come out from. Like, there is deep ignorance as to, how a human body functions, especially when it comes to sex and when it comes to reproduction, that many women do not know even the basics. So, without teaching them what exactly happens or without empowering them with information, how would you ask them to make decisions, right? Like if they don't know anything at all about a topic, they are definitely not in a place to authoritatively make good decisions for themselves. And that is not to say that they don't have the right, but it's also to say that there is a lot of gaps before which that person can feel confident in making decisions for themselves. On the flip side, and this is one of my favorite things I read on Tumblr, I could not find it again to put it up here. Patriarchy hurts men, that too we always talk about, but patriarchy hurts men the same way that punching someone in the face also hurts your hand. In the sense, these are things that I have actively seen on the ground in a way that women not making decisions how it affects the men in their families. A man in my building fell sick and he needed to be taken to the hospital. He only had his wife and children living with him at the time, and the wife did not know where the money was kept, couldn't make a decision on which hospital to take him to. So she had to wait for a long time until a male relative came to help, and that took a long time. In fact, I was called to sort of help out here, and she was asking me if I could accompany this person and go to a hospital in the middle of the night. And this was just some random person in the building, and I was just so surprised that and we had to wait for a bit till a male relative came. A man admitted to the ICU had to sign checks for his own treatment in the ICU and hand them over to his daughter before he could be intubated. And by intubated, I mean like you get an injection and then you get made unconscious, and then there's a tube that is inserted and you get breaths via ventilators, which means that in that time when he was signing those checks, this man was really not in any state. Like he was really sick, he was breathing like that state, and he had to still make financial decisions about his own treatment. Like just imagine the kind of stress or whatever that person was going through. A husband and wife came to my outpatient clinic, and this happened when they were waiting in the line. The husband started having a seizure. So after giving some, primary first aid, I advised the wife to take him to the hospital in an ambulance, and she was just crying. She didn't know how to reach out, how to get an ambulance. She didn't have any money apart from what consultation charges she brought for me. We had to find an auto. She didn't know where the next hospital was, where to go. It was like very messed up. A patient who died in a COVID-19 ICU, again, personal experience, was buried by the hospital without the wives or kid getting to see them even one last time because the primary decision maker was an uncle, and we were contacting him over phone, and they were living in a village, and he did not even tell the wife that the person passed away because I called him at around 3 a.m. at night, and he said, if I say now, she will want to come see, and I am not willing to bring her. So you just do whatever you want with the body. Tomorrow morning, I will tell her. And it was crazy. Like, I could not even get him to hand the phone to the wife. My best friend, who got admitted after having a life threatening accident, it was a car accident. Then he had to file his own insurance claim and figure out finances to pay the hospital bill. Like, he was unable to feed himself. His mother was feeding him, but she had no idea where the money was or what can be done. It was really sad to see that he was making phone calls and visiting him. I was feeling so sad. Like, right now you should be resting. Why are you doing this? Many patients accompanied by female relatives do not get right medical care on time because women are unwilling to make any decisions, or they're unwilling to sign on consent forms also. So a lot of precious time is lost waiting for a man to come. This is an ICU physician, and he was telling me this. And this I agree in the sense. Now, you would ask me if it is so risky, like, especially that person in the building, he had liver disease, he was known to be very sick. We were just talking to each other about like why he did not teach his wife anything, considering the fact that he was this sick. Like, you must empower the people you live with to take care of you, right? But what you realize, like, even how horrific these things are, these are rare things. They don't happen to everyone, and they don't happen all the time. However, the power that a man or a male person can control on an everyday basis far outweighs this. You could ask your wife to shut up, you could ask her to do whatever your chores you need to be done. You have ultimate say in what happens in your family, all of that. So 99% of the time things go well in for men when they shore up that kind of power. Only these rare occasional cases of like sickness and whatever does it go wrong. So just like anything in patriarchy, of course patriarchy hurts men as well, but the benefits that they get far outweigh the hurt, and it's really difficult to explain to them to give up some of those benefits, and especially access to resources that they get by subscribing or to patriarchy, to get these benefits instead. But yeah, so moving on from, like, we have now defined the problem. We know that the problem is very, very widespread, and that multiple layers of people exist that control women's decision making. We have also talked about how many what nuances there are, especially in terms of information asymmetry, and never having made decisions, and like also about how it affects men. So here I would like to talk about, like, especially an informed medical decision. To make a good decision, what are the components that we need? We need to describe this first before we go on and talk about solutions as to how we empower women. First is reaching the health provider, which means that you need to have a certain amount of mobility, certain amount of say in saying, I'm sick now, I want to go, and in choosing the healthcare provider that you would like to go to. Second would be understanding the condition, which is something that your health provider will explain to you. And then you should also have some kind of like ability to gather all information about it, like, looking up things, reading about stuff, etc. Then you get evaluated, then you evaluate the choices that are given to you, like benefits, risks of a particular treatment, what alternatives exist. And the last thing that you would evaluate is nothing, which is, if I don't do anything right now, will my condition still be okay? Will it resolve on its own? Or, what or would it get worse? Sometimes people can make a decision to do nothing about a certain thing, which most patients do, like for example cosmetic concerns and whatever. So it's called bran. And this kind of evaluation needs to be done, and then the patient must also be able to define what goals they want from a particular treatment. Like for example, um, you would say, I would how would you want to feel? Or in the sense that there might be a particular pain for which there is surgery or there is medical treatment. Like a patient would pick surgery if they say, I want to just be done with it, I don't want to keep struggling with this for the rest of my life. This sometimes when they have tonsils, right, and that keeps getting inflamed once in a while. So some people may say, I just want to get rid of my tonsils and never get this. But some people would say, I'm scared of the surgery and I would rather keep taking medicines once in a while, and that is acceptable to me. So to be able to define what is acceptable to you, what is your goal from this particular treatment, and then choosing that, these are the components that are needed to make an informed good medical decision for anybody. So what are the bottlenecks that women face? First, the state itself does not provide much in the way of mobility and transport, especially safety, while being able to move from one place to another, especially to health centers. There is a lack of access to money, and the system is also completely underprepared for female autonomy. In terms of medical, or I would say health education, like in terms of education for health workers, there is a lot of medical misogyny in the system, a lot of implicit bias. There are people who say women make up symptoms just because they want attention. There is refusal to take women's pain seriously. And then there is information asymmetry. People do not know how to give information to women, especially you have to meet them where they are at in their level of understanding, and then build their understanding about their condition. And these kind of things are not taught to us in as ed as health professionals. And then leveraging relationships, how intra and extra familial support might help, because we know that families are the primary places where autonomy for women are stifled. And solutions could be at that level, and at the level of an individual woman, because none of us make decisions about anything unless we are confident in our ability to make decisions. And also, we need to have a certain amount of resilience towards making mistakes and being okay with making mistakes, and knowing that making mistakes may not necessarily mean that we are bad decision makers. So there is a need to build up confidence at the level of the individual woman. I have put that very last because individual solutions are individual solutions in the sense that they are not primarily what is needed. We have to really look to the systems to make solutions. In the level of state, now I have given this talk about 3 years ago, and my understanding has evolved over these 3 years. A lot of nuances that I currently have added are from my learnings through the past few years. As I have sat with this problem, what I realized is that a good universal healthcare system can tackle many of the initial barriers, and India already has the bare bones of what is needed to equip the infrastructure for female autonomy. For example, like as I said, take money out of the equation, familial control actually considerably weakens. Like if say for example a woman has some pain and she's telling, like, and this has happened, we sometimes husbands bring wives and then we tell them that this is the diagnosis, this is the treatment, or we need further tests, and then the husband would be like, oh no, we don't have money. And usually a lot of resources get allotted towards the care of men because they are primary breadwinners in the family. So what if a man has a health concern, very easily addressed, a woman will always wait till the last time, last minute. She'll tell her family, they will not bring her to the hospital quickly enough. They only until she stops being able to do housework will they bring them to the hospital for it. All of that. But if money is taken out of this equation, a lot of these things could actually be addressed, I feel. Like high quality healthcare, including like diagnostics and drugs in the public healthcare system, means that there is no middleman controlling the purse strings. So a doctor and a patient can maybe collaboratively make decisions, even make choices to do more expensive things that are good for the patient, um, which, like, say, a husband would refuse to shell out cash for. So, and free, reliable, and safe ambulance services, which a woman can avail to go to a health center. Um, and like trust in these ambulance services may then allow um, the family members also to let the women avail them. And asha workers are already doing this work by accompanying women to clinics and health centers in the absence of their relatives. But ashas are so underpaid and their work is not recognized. So compensating the ashas, putting more money into the system there, recruiting more health workers to strengthen the asha system would definitely help in allowing women to go to the health facilities on their own. Better infrastructure to allow for privacy. This is something my partner told me. Many women who are seeking to have abortions, especially without their relatives knowing, they are not going to come to health clinics where there is like a large waiting room which is overcrowded, too many people, etc. That is why they end up going to these people who are informal providers who may not be well trained, because they are awarding them privacy. So better infrastructure to allow for privacy in a way that people are not monitored, that would be very useful. Especially telemedicine might also help. But then I am also not for advocating for too many technocratic solutions, because then that would put these solutions at the hands of like more privileged people. A law to prevent violence against health workers is very, very, very important, because, as I said, any place where a woman makes a decision for herself, violence is how the family, the community, or the state retaliates. Now, look at how what happens to women who choose their own life partners. What the family beats her up. They have to go stay in shelters for protection, etc. And when women make, or when the doctor facilitates a choice that a woman wants to make for herself, then the doctor's life is in danger. So to prevent this, there has to be a law to prevent violence, and more than that, appropriate security measures within clinics, and an easy accessibility pathway to the police, where the security people can inform the police in case something is happening. And the state has to take a rights based approach to medical care, and the state should be willing to withstand community and religious backlash. But I would say that for this to become reality, it's going to take a long, 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 long time, um, if at all. Now, talking about education, we have to have comprehensive gender education in all courses like MBBS, nurses, pharmacists, lab technicians, community health workers, even security people who are in hospitals. You have to understand exactly what is the reality in which women live, from the community that you are going to serve. And in order to sort of, it's called attaining cultural competence, which is very, very needed, especially if the health worker themselves is from a very privileged background, then they may not understand the realities that women face. um, and education on medical misogyny for all stakeholders. Medical misogyny is real, it is very, very real, and it's really sad that a lot of health workers do not know about this. And coming from like a medical background, I can tell you that my curriculum did not prepare me to um, see what exactly exists on the ground, which was really sad. And we have to teach individual autonomy as a moral imperative, and educate all stakeholders to engage in collaborative and shared decision making. For example, like if you see many health workers, right, they themselves do not have the autonomy to make their own choices in their houses. So what they then bring to the table in terms of services for women also get colored by their experiences. For example, like a doctor or a nurse who is not allowed to make decisions about how many children she has, she would bring that exact same lens to providing service to um whoever is seeking service from them. So definitely teaching individual autonomy as a moral imperative is very, very important, not just for health workers, but generally. And more education and employment of female medical social workers in the health context, so that they can help us make better decisions, if they know the context, etc. Again, as I said, female health workers face misogyny and medical misogyny. As a doctor, even I am terrified of accessing care from the healthcare system, because um, like Like, I have had PCOS, and every time I visit a gynecologist, all they tell me is to lose weight. And it's like really like, and even after I have lost weight, they would say lose more weight. And it's like very, very invalidating system. Like, and that makes me think that as someone with so much knowledge and power within the system, if the system is so traumatic and violent and painful for somebody like me, it's clear that it is, the system itself is built in a very violent and traumatic way. So for them, then for me to uh, offer more empathy towards a patient, like, people always ask, so if I didn't get it, then why should I give that to somebody, that kind of a thing. So most health workers are themselves only carrying out the treatment they have received from the health treatment to others, community care during their care. Sometimes, and also we have to understand that there is a limitation in what a health worker can do. And sometimes all we can do is ask the woman what she wants and facilitate communication between the woman and the family. We could also tell the family that what the woman wants is actually good. Like, it's a good choice, and she also wants it. Do you think you can still consider this? So, definitely, as somebody with a little bit more power in the system, advocating for our patient is something that health workers should be doing. And this is something, the next thing is something that I really, really believe, whether or not the woman is the one who's going to make a decision, she needs to hear every nuance of her disease. Even if the health worker knows she's not going to make the decision, it is a moral imperative to explain to them. You can, even if you have to explain it twice or thrice, I think the woman should hear all the information. And we could then, to make it easier, we could use image or video based aids, use sculptures or human body models to point out organs or explain procedures, give information fact sheets to read through. So, what I believe is you have to meet the patient at their level of understanding and really empower them with information so that they understand their condition well. For patients who are coming for antenatal evaluations, this is for pregnancy evaluations, right? So this is a very nice and unique scenario where you get to stay with the patient for 10 months. They will be coming back to you and then they will give birth. So in those cases where you can actually develop and sustain a long term relationship with your patient, to ensure you give good information from them to them from the start, so that by the time when they're giving birth and they have to make decisions, they are well equipped. And you also let them make small decisions for themselves, and let them see that they're making the right decisions, so that by the time comes for high stake decisions, they are sort of empowered. And the last thing is, I feel this, doctors or non-doctors, everybody has experienced this. You would go for a consultation and then you would ask your doctor, so what can I eat with this condition, and then you would hear this, and then they're just like, long sufferingly telling you actually food doesn't matter. So those are things that I think that really needs to be addressed. And patients also ask things about whether I can eat this before food, after food, and then the doctor goes, I think that needs to stop, because, like, especially a woman patient, the area where they can control or where they can make small decisions, right, more often than not, it involves food. So you give them these options, you tell them you could do this, you could do that. It's a very respectful way of fostering competence in women patients and women relatives, I feel. So this is one thing that I really believe, that, like, doctors should answer all questions, no matter whether we think it's stupid or not. So now let's talk about relationships. um so I'm starting this with a study on extrafamilial relationships, because fostering intrafamilial relationships for decision making is a very difficult thing. Extrafamilially, like women who have friends outside of their family, they tend to be able to make better decisions and have a support system to make decisions. This study was done in Jaunpur in Uttar Pradesh, where they gave this clinic voucher to women and said you could come with a friend and access any kind of family planning services for up to rupees 2000 rupees. And they said it the person you come with is a female friend. It should not be anybody from your family. So when women showed up with like female friends, right, even they were able to make decisions, they were able to choose what they liked. And some women even went on to make decisions that their family opposed, but they were okay with for themselves. So this shows that and again I repeat, autonomy of women primarily stifled within families. So having extra familial support, especially from other women, very, very important. Patriarchy really messes this up by using patri locality, where women marry and move into their husbands' households far away from the people they have grown roots with, and end up not having that kind of a support. But it's very important that wherever women are, they make friends outside their family. And also, power of the collective empowers women. This study talks about how self-help groups in Tamil Nadu, where microfinancing and a little bit of skill development were given to women, and they realized that about 10% of those women went to make autonomous decisions about their own health care. So this shows that, like, having collective support and might help women make decisions for themselves. This is about intrafamilial um, relationships and leveraging them. This is a very brilliant book. It's non-fiction. Veena Venugopal is a journalist who interviewed around 10 to 15 women about their relationships with their mother-in-law and how that affected their family, and sort of made really interesting points. I think everybody should read this book. This allowance for cruelty within families is universal, but it's especially pronounced in India, where the family reigns supreme. And the most puzzling aspect of mother-in-law behavior is her desire for absolute control. There is no room for negotiation. So what we say is that there is importance for people to identify that for a woman, the key decision maker in the family might not be her husband, or might not be any is most likely and most often the mother-in-law. So influencing her, talking to the mother-in-law and helping them sort of see the point of view of the patient might be of value to a health provider. So there is this study called Convincing the Mummy G study. So as you see, in Indian households, there is a misalignment in fertility preferences. The ideal number of sons that the mother-in-law thinks, or ideal number of children that the mother-in-law thinks a person should have would be three. And the ideal number of sons, if you see, the women don't want sons, but the mother-in-law wants at least two sons. So there is always the case that, like, and in the end, more often than not, what ends up happening is what the mother-in-law wants. So it's, in some places it might be worth it to have conversations with mothers-in-law. I do not um, In this study, it has shown that some amount of good results were there, um, but yeah, just identifying her as a key decision maker and having a conversation with them would might help. Now, this is a very, very brilliant book called Real Life. This was released, I guess, last year. It was written by this author called Amrita Mahale. It sets this beautiful context. Even after, um, like, yeah. So even after all these years of living in one place, it will be 37 years this December. I can bet that most shopkeepers in the colony don't even know my face, says a mother in law to her daughter in law. Now, the context is that they are discussing whether a woman going out may lead to her getting assaulted, may lead to her being a victim of a violent crime. So the mother-in-law is telling that even after all these years of living in this place, like of 37 years, most shopkeepers don't even know my face. She explains that after she arrived as a newlywed, I once saw a man follow me from the market to the house. Your dad was very upset, and I promised him that it would never happen again, and it never did. I started sending your dad to the market, or I would make sure he accompanied me. And later, I began to make sure everything happened through the phone, she says. That is how it's done, said my father in law with an air of victory. And this was long before your Swiggies and Zomatos and big baskets. I have managed to run a household for 37 years without leaving the household, unless mother in law adds. The daughter in law replies, and you're proud of this? I asked her. If I were in your place, mom, I would have been very, very angry at the world for robbing me of half my life. Now, the reason why I'm putting this and this other brilliant quote from The Vegetarian, where the sister of the vegetarian talks about her, she says, she was no longer able to cope with all that her sister reminded her of. She'd been unable to forgive her for soaring alone over a boundary she herself would not bring herself to cross. Unable to forgive that magnificent irresponsibility that enabled Yonghae to shuck off social constraints and leave her behind, still a prisoner. Before Yonghae had broken those bars, she'd never even known they were there. This means that what I'm trying to explain with these two books is that most women do not even know that the lack of autonomy that they have is something of a problem. It is only when you see somebody else making better choices for themselves, or and that you realize that those chains were there. And it's also sometimes women also glorify the chains that they that are holding them, because that is the only way you can cope with the life that you've been given. Like, if the mother-in-law again actually perceived that 37 years of her life was wasted, then how would she live with that? So, in the way of an individual woman, most of the time Indian women do not recognize the right to their own life beyond the duties and responsibilities to their family. A woman understanding the extent of cruelty that is being meted out to her is a rarity and not the norm, said a psychiatrist. So we need to upskill and empower women to make decisions and to allow them to fail and make mistakes and develop resilience. But this is at the level of the individual women. How often is possible? I don't know. In 2015, there was this interesting thing that the Rajasthan government did. It's called the Rajasthan Nutrition Project. This was because Rajasthan was a very food insecure state. So they got women who are parts of these self-help groups, now the small self-help groups, and then they taught them what to do about food. So they taught them what you should buy if you have this much amount of money, what is more of a healthy food, how you can portion out in a way that your family remains you know well fed, etc. And they also help them make savings and make income generation, etc. So what they realized after studying the project was that not only did food insecurity actually decrease, malnutrition decreased after women understood how to buy food, what to buy, what to cook, etc. They also became way more autonomous. If you see this table, you could see that wives' active participation in decision making sort of increased regarding food, sort above. The third row shows you husband alone making decisions fell to 3%. Husband alone making decisions on how money is spent fell. Wife's ability to go to a healthcare facility alone became three times of what it was. Wife thinking domestic violence by husband is okay fell. So, what I'm learning from this is that teaching women how to do things, even if they are unrelated things from healthcare, even if they are just things that are relevant for her, and upskilling her to make small, small decisions, definitely will have like a ripple effect for a woman then making decisions about her own healthcare. And this is something that I really think is very, very important, because this kind of conversations are not happening very often, and it needs to happen. Like, a lot of doctors have or a lot of health workers have a lot of nuance. What we need to do is talk to people who are on the sly fostering women to make their own decisions, like health workers who are letting women have these abortions even if their partner is not around, health workers who are giving them the contraception when partners are not around, health workers who are helping women make their own health decisions. They're all doing it very secretively because, again, fear of retaliation. Somewhere along the lines, we need to talk to them and ask them, what is it that is helping you do this? and sort of put together a qualitative, maybe a qualitative set of narratives with which we can then decide how to redesign the health system. I really think that the comprehensive gender education that needs to be there for health workers also should be using these kind of evidences from health workers who are doing this work. Finally, this is the last thing that I want to say, and this is one of the most important things that I learned as a health worker and as a feminist. In this context, again from Heartlamp, Ashraf is a person whose husband has left her. She has a baby who is malnourished. Now she is now working as a household worker at the house of this feminist Islam scholar. And now she wants to learn how she can ask her husband to support her daughter because the girl is very, very sick. So the Islam scholar answers her, do you know, Ashraf, if a daughter is born, it's as though the Prophet himself has saluted the house. Oh, leave it, Appa. How many times should a Prophet salam fall on a poor woman's house like mine? She says. She is not taking it as a blessing. You are mad. The Prophet himself had only daughters. A son was born but died when he was still a child. Have you read about how much he loved his daughters? Have you learned about it? His Bibi Fatima was his life. They were living proof of the bond that can exist between father and daughter, this woman said. Ashraf did not understand a word. Her mind still revolved around thoughts of Munni, who's her daughter. Is there no medicine for this? She asks. There is. Why won't there be? Why don't scholars tell women about the rights available to them? Because they only want to restrict women. The whole world is at a stage where everyone is saying something must be done for women and girl children. But these people, they've taken over the Quran and Hadiths. Let them behave as per these texts. Let them educate girls in madrasa, not a madrasa education, but in schools and colleges. The choice of a husband should be hers. Give them that. These eunuchs, let them give meher and get married instead of licking leftovers by taking dowry. Let a girl's maternal family give her a share in the property. Let them respect her right to get divorced if there is no compatibility between the man and the woman. If she is divorced, let someone come forward to marry her again. If she is a widow, let her get a companion to share her life with. What are you saying? Ashraf felt like she had lost her senses. So now again, our Islamic scholar is giving this whole rights about what rights women have in Islam and what women can do, what they should be given. Ashraf nodded her head, disappointed. She did not want any of this. What can I ask about my Munni? She asks. Now, on the ground, and I'm so ashamed of admitting this, there used to be patients when I was much younger who would come and say things like, I've had a daughter now. Like, they've given birth, it's a daughter, they're disappointed. They're like, my life is not going to be the same. And or they come and they said, without my husband, what could happen? A woman is nothing without her man, that kind of things. So then what I would do is launch off on these feminist tirades of like, aajkal ka duniya mein everything is equal, you should be fighting for your rights, and you should be independent. Or sometimes I would tell this is why you should have studied, things like that. But it doesn't help. Shaming women for something that is completely not their fault is something that feminist doctors have been doing, and we should really pare back on this. And this is something I learned much, much later. This other doctor told me that she's constantly vigilant when she's counseling women about topics such as teen pregnancy, contraception, etc., because she would not want to shame their lack of knowledge or agency. She had to learn a lot of feminist discourse to find out the right language to employ. For me, also, it is an eye opening moment because most female doctors, when the patient talks about their lack of agency, tend to bristle and we launch into lectures about women's empowerment. But at that point, the woman is all she is saying is that I don't have the power, and that is real. Like, she is only expressing her own reality. And it's really important that at that time we do not shame them. Women's ability to decide is one of the biggest sustained development goals for um, one of the main indicators. So when we say that, healthcare access, we don't mean only stocked shelves and trained staff, because access depends on whether the person who is accessing healthcare is able to make decisions and autonomously decide what they want. So these are my references. I would be able to send you the slides if anybody is interested. Thanks a lot for listening to me.
Thanks, Christinez. That was a very rich and thought-provoking uh, talk. And something that really jumped out at me was it's really not my favorite book, but because it's very difficult to read. But Paulo Freire talks about this a lot. And he says in The Pedagogy of the Oppressed that those people who are oppressed for a very long time or live in structures of domination for a very long time often come to doubt, they internalize that oppression and they come to doubt their own capacity to choose. So, this means that you can't just declare their autonomy as a right. You have to, it has to be created within the social conditions, and the system has to be encouraging and towards that, be designed towards encouraging that autonomy. So I think that's something that really jumped out. And Pedagogy of the Oppressed, of course, always talks about these structures. There's a question that I want to open the floor to anybody who'd like to ask a question. But just before we do that, just to break the ice, I want to ask Christian as a question. If I were to come to you as a patient and I want to stand up for my own decision and make sure that communicate with you that this is a decision that I want to take, is there something that you would look for as a doctor, or something that I could say to you that would make you encourage me? Is there anything that we can do as a patient to help the physician understand that I want to take agency, whatever else my family may say? So, is there something we can do from the practitioner's point of view? I can understand because I am a practitioner and I'm aware of many things that come in the way. But as a patient, do you think somebody could come to you and say something that would make you pay more attention?
So one thing that I have realized is that even there have been times as a practitioner that I have sometimes pushed for a choice that my patient didn't want, and they end up coming back and telling me that it was unacceptable. So this has happened to me quite a bit of times, where you would say, okay, you take this medicine, it will only cause more gas, but other than that, the other option is more expensive, but something like that you would just offer. And they would say, no, I don't think I can handle gas issue. But you would be like, but it's a good medicine, you should take it. But then they would come back and say that, I didn't sleep all night because I had gas and I didn't want that. And uh, so then I realized that these things that are very theoretical for a practitioner are actually symptoms that people need to live with. And you don't know exactly the kind of environment that they live in, where like this person could be a student, and if she didn't sleep at night, then like she's going and sleeping in class and getting yelled at in the morning. So there is a really important thing that any health practitioner or anybody should realize, is that people understand their environments, and people are are experts of their contexts in a way that you are not. And if they're telling you that a certain choice makes sense for them, it is very likely that it does make sense for them. So for me, it was a lot of like, making mistakes and learning. It's about like every single time I have pushed a choice on a patient which they didn't want to make, they have always come back and told me, this is something that I didn't like and I told you. So for me, it was really important to go through those 2 3 situations, and after that I was like, no, 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 you only have to make a decision. I would collaboratively help you.
Yeah, thanks. Anybody would like? I'd like to encourage anybody to ask a question. If anybody has a question for Christinez, I'm also aware that many people who are attending are in Kerala, and I'm aware that Kerala has. I have heard that Kerala has a matriarchal, matrilineal society. So, does this what Christian has said? Does it sound like a distant reality, or does it sound like something that you could relate with? Any comments, any questions? The floor is open.
It was quite a deeply disturbing session, Dr. Christinez, because even though these things are already known, still to see it all in an organized manner, arranged and accompanied by the statistics is quite, well, to say the minimum, disturbing. And we are talking about empowering women by educating them. But is it enough to just empower women? Because you yourself had told about patients asking you, will you be able to explain this to the husband, to the father? So, isn't a great focus? Doesn't the need be a greater focus to empower the men too? I do think that the patriarchy does hurt men, and we should focus on those aspects and also make them aware that they are being hurt. So I think that we should also devise such means to make men understand and make men be empowered to be able to express their emotions, to help their wives, mothers, sisters to face life in a proper, strong way so that they too can live their lives better.
Thanks a lot for inviting me to speak, and especially I really thank you for allowing me to call Gayatri as the moderator, as like my best friend and my co-conspirator in half the things that we do. It was really, really nice to have her um, be here with me, and it really did a lot for my confidence also. And thanks a lot, ma'am, for identifying and calling me here. I My dream forever has been, when I was a child, to be an English teacher, which never ended up happening. So I feel so happy that I was able to talk in front of English
By
scholars.
bringing all these novels, all these modern novels, and okay, Hard Lamp, and every one of those celebrated novels, Vegetarian. Okay, all these novels had the very relevant quotes, the very relevant situations which you could apply to our own lived experience in India. That was quite interesting. And I hope that such people will come and talk more and more. And I would also listen to Dr. Gayatri sometime later about her experiences too. And I'm really glad and thankful that I could reach out to you. This is very important that literature people and people of other disciplines should know about the lived reality of our experience. Now, since time is getting late, uh, let's ask the participants. If you want to, you can ask some questions, please. Otherwise, we will soon wind up the session.
Doctor, I do have a question. Am I audible?
You are, you are.
Yes, so it was wonderful. It was really a wonderful session, something very refreshing and new as far as a literature scholar or a research scholar is concerned. So my question is, like you spoke about female agency and how women need to be educated and empowered to speak for themselves. But my question is, do you think that women demanding to be taken seriously has helped bring more research attention to conditions that were ignored for a long time. Like I keep reading about this endometriosis. I mean, I don't know much about it, but like some, gender bias related to the research of endometriosis, diseases like endometriosis. So, do you think that this is also the female patient advocacy is sort of helping the research as well? I mean, is it happening in that sense? That was my question. I hope it is clear.
Yeah. So this is a very important question. And what I would like to say is that patient advocacy per se has not been so big in India, but patient advocacy abroad has brought about a lot of research in these conditions like PCOS, endometriosis, PMDD, and all. And that research used to generally trickle down to India and other global south countries earlier, but now very recently, about a year or so ago, there are new NGOs, for example, who are advocating for um, research in menstrual disorders like PMDD especially. Like there is this NGO called Boond who keep talking about it, and so it's very very new in India. It's just been about a year or so, but patient advocacy abroad has been trickling down for a bit prior. But definitely, yes, women documenting their lived experiences, especially now, to people talk about it on social media, people put up things. After women talked about their experiences with living with ADHD, for example, the first ever study on qualitative experiences of women who are living with ADHD in India was then published. It's by Dr. Itisha Nagar. You could look at it, it's really good. And this is the first ever study of its kind, and that is the only piece of research on Indian women and ADHD that exists as of today. I really hope that more things would come up. So I agree, like people talking about things is inspiring research, and that's really important. All experiences should be documented, even if they're outliers, as starting questions for research.
Thank you, ma'am. Thank you.
Thank you,
Any
ma'am.
other questions? Yeah, go ahead.
Yeah, ma'am. If anyone have any questions,
Yeah,
shall we wind
just
up?
before we wind up, I'll just take us one more minute.
Hello.
Yes.
Yeah, can you hear me?
Yes.
Did someone have a question? Am I interrupting someone? No. Okay. So before we just wind up, one great way of taking agency is one of the tools is, and now that has recently become legal in India, is to look at an advanced care plan. And this is available online. There are some, we can share the links with Professor Betsy, with the organizers, with Christinez, and anyone who wants to get in touch. This allows you to write on paper what you would like to happen in case you are not able to speak for yourself. It becomes a legally binding document that the doctors will have to listen to. So that's a resource that can be used by anybody, whether female or male, to have at least a little bit more agency over their mm, health. And I mentioned this because I wanted to end on a note of hope. Thank you. Thank you so much, Prof.
Thank you, ma'am. So, as we come to the close, for the participants, I would like to say there is a feedback link posted in the chat box. Please submit it to generate your e-certificates. And now I invite Hridya PS, Research Scholar, St. Aloysius College, for the vote of thanks.
Good evening, everyone. Am I audible?
Yes, Hridya.
At the outset, I sincerely apologize as I am unable to switch on my video at the moment. I hope you will kindly excuse this. I am Hridya PS, Research Scholar at the Research Center in English, St. Aloysius College. It is my privilege to propose the vote of thanks as we conclude to this session and reflect on the inspiring journey of Chrysalis Season 5. As we come to the close of this session, um, it's my privilege to offer a few words of gratitude while reflecting on the meaningful journey of Chrysalis Season 5, the commemorative lecture series organized by the Research Center in English at St. Aloysius College in collaboration with IQAC. What began as a tribute to the cherished mentors of this institution, Reverend Father Anthony Kuttikar, Dr. Denya Menon, and Professor M. Paul Davis, has grown into a vibrant academic space for dialogue and reflection in the humanities. Reaching the 57th session today is not merely a milestone in numbers, it represents a sustained commitment to scholarship, curiosity, and collective yearning. Over the course of this year, Chrysalis has brought together scholars who opened up a wide range of conversations from literature and philosophy to cinema, digital memory, feminist critique, ecological thought, post-human studies, children's literature, and now public health. These lectures have continually reminded us that the humanities remain deeply connected to the complexities of contemporary life. We are immensely grateful to the distinguished speakers who enriched this journey: Dr. Christina T. Joss, Dr. Siddhartha Pradaba, Dr. Kavya Krishna K., Dr. Vrinda Verma, Dr. Ratna Moles, Ms. Lakshmi S. Menon, Dr. Anusha Hegde, Dr. Shyama Shashidharan, and Dr. Christinez Ratna Kiruba. Each of them has brought unique insights and perspectives that made every session intellectually engaging and thought provoking. And also, our sincere thanks goes to the moderators who guided these conversations so thoughtfully: Dr. Lakshmi CM, Dr. Joyjit Ghosh, Professor Rajani Singh, Dr. Abhida Balagopalan, Dr. Sheba KM, Dr. R. Vijay Lakshmi, Dr. Anita Jose, Dr. Disha Tomji Varghese, and Dr. Gayathri Sharma. A particularly memorable moment in this journey was the celebration of 50th session of Chrysalis, marked by the national seminar. That event beautifully reflected the spirit of Chrysalis, encouraging emerging scholarship while building meaningful conversations. At this moment, I'd like to express our sincere gratitude to Dr. Dayasiri, our principal, Dr. Atita K. Unni, Dr. Susan Joshi, for their continued support and encouragement. A very special word of thanks goes to Professor Dr. Betsy Polsey, Director of the Research Center in English and Coordinator of Chrysalis, whose vision, dedication, and tireless efforts have sustained this lecture series throughout the year. And I also thanks to acknowledge the efforts of the organizing committee, faculty members, research scholars, and volunteers. And finally, our deepest thanks go to the participants and audience members who joined us session as after session, bringing curiosity, thoughtful engagement, and enthusiasm for learning. It is your presence that truly keeps Chrysalis alive. Thank you all. Thank you for being part of this journey.
Thank you, Hridya. So, as we come to an end, let us carry forward the knowledge, connections, and inspirations we have gained here today. So, once again, on behalf of St. Aloysius and Chrysalis team, I thank everyone for your valuable time and cooperation in this session. So, see you soon in the next academic year. Thank you.
Excuse me, ma'am.
Yes.
Yes,
Thanks a lot for
That
having
link is
me.
not opening for me.
we'll just look into that. Please wait.
So, Nima, so
Yes, ma'am.
to all our research scholars too.
Ma'am, it's not opening. That link is not opening.
Yes, we'll look into that. Please keep the link with you. The same link will be used for the
Or
feedback.
was do this need be, or we can individually be on if there is an issue. Okay, thank you, brother.